most of you know me, but for those who don't, if there is anyone, my name is Renee Ramsey. I'm a nurse. Been a nurse for 6 years with Med Center Air, and I'm also an EMT here at Matthews Fire Department. In total, I've been in healthcare for 10 years. And I'm currently taking instructor methodology as part of that class. We have to teach certain lectures. And today I'm going to be talking about acid-base balances. Before we get started, if you need to use the restroom, it's out that door to the right. Keep your cell phones on vibrate or silent. And if the tones do go off, since we are in the fire station, just ignore them, and we'll pause the lecture, and then we'll restart as soon as they're done. So, can anyone tell me what acid-base balance is? Very general overview, if you have an idea.
Y'all are terrible.
I got nurses and paramedics, and nobody can tell me what they're
Ashley.
Ashley, hit me. What you got?
So acid is like, if you're looking at the scale, acid is anything under 7, because 7 is considered neutral. Your blood is neutral. Whereas base is anything above 7. So it's a balance between what your body can handle, cannot handle. Your body can't be too acidotic, your body can't be too alkalosis.
Sure. Yeah. So, acid-base balance. Exactly. It is a balance. It is measured in hydrogen ions, so you don't want too many or too few. And the way we measure hydrogen ions in the body is called the pH scale. Like you were saying, it is a scale from 0 to 14, with 7 being neutral. When you think neutral, you think water. Our body works to keep us, like anything, we don't want to be too hot, we don't want to be too cold. So in this case, we don't want to be too acidic or too alkalotic or basic. Hydrogen ions, they usually attach themselves to other molecules, and that's how they become either acidic or basic. Mainly they attach to protein molecules, and what they do, the protein molecules do is affect our cells, how they react, the integrity, their permeability. So if this balance is off, this pH balance, then our cells at the molecular level won't function and our body won't function properly. Like I was saying, it ranges from 0 to 14. Our blood is actually 7.35 to 7.45, so it is more alkalotic than it is acidic. It's not actually neutral. And that's important to remember when we're treating these different imbalances. An acidotic state is anything under 7.35 on that pH scale for us when we're talking about the human body. And alkalinic or basic is anything above 7.45 on the pH scale. So pretty straightforward, I think, so far. This is just a basics chart. Gives you kind of some references. So when you're talking about acids, battery acid is it's 0 on the pH scale. So that's why we tend to not want to get that on our hands when we're messing with cars. If you're looking at urine, it's actually acidic for the most part for most people. It can change, but it's close to neutral, but it's still considered acidic because it's 6 on the pH scale. And then you have things like ammonia, bleach, and drain cleaner that are more on the alkalotic. This is why when we have patients that come in that have ingested this, we tell them not to vomit because it can burn their esophagus and everything like that. All right. So, how does our body keep this balance? We have buffer systems, and the 2 major buffer systems are the lung and the kidneys. One is faster than the other, the lungs being a faster regulating method, and the kidneys being a little bit slower. So, without reading, how do we think the lungs work? We'll start there. Does anybody know how the lungs work on a very basic level? Big.
Air goes in, head out, and blood goes round and out.
So good. So we're breathing in air. What's coming out? CO2. Do we think that is acidic or basic? Acidic. So when you're talking about the lungs and trying to regulate the acid-base balance, if our body gets too acidic, we're going to want to breathe faster, blow off more CO2. And vice versa. If our body gets too alkalotic, we're going to start to breathe slower and hold on to more CO2. Straightforward. When you're looking at patients, so say you have an overdose patient, whether in the field or in the hospital, how do they typically breathe? Slow. So they're breathing slow, they're holding on to CO2. Would you expect them to be acidotic or alkalotic, basic or acidic? Basic.
When they change, they start off that way, but the slower they breathe for a more extended time, when they start building up acid. Camp in class all day.
So, exactly, and you will get that buildup of CO2, your pH will decrease and you'll become acidic. You have chemoreceptors in your body and they respond to that. When your pH drops, your ventilations increase. When your pH goes up, your ventilations decrease. Yes.
Is this hold true for COPD patients also?
Yes, they're a little bit different, and we'll talk about that a little bit when we get into the imbalances. So I'll hold on to that question and I'll come right back to it. Kidneys, like I said, are a little bit slower to work. They work by excreting acids and bases based on what your body is doing. They can take up to several days to correct an imbalance. And the way they do this is through bicarbonate. They can produce bicarbonate ions and they can replace your depleted supplies, but also when bicarb builds up, which is a base, I should say, it can excrete that bicarb and get you back to a normal state. And I think the kidneys are a little bit more complicated to explain, so I do have a video on the next slide that I wanna show you. YouTube, find anything wrong in YouTube.
There are two major organ systems in our body that function in acid-base balance: the respiratory system and the renal system. The respiratory system's role in acid-base balance is in regulating carbon dioxide levels. Take, for example, a person who is hyperventilating. The faster a person breathes, the more CO2 they expire. And going back to the Henderson-Hasselbalch equation, as a person hyperventilates, CO2 decreases, and as a result, pH increases. The respiratory system can also drive someone to lower their pH by hypoventilation. For example, when a patient holds their breath, has a decrease in respirations, or when there is poor gas exchange across the alveoli of the lungs, CO2 in the blood is retained and therefore increases, leading to a decrease in pH. So in summary, the faster you breathe, the more CO2 you blow out, leading to an increase in pH. The slower you breathe, the more CO2 you retain, leading to a decrease in pH. Alright, so for our first example, let's explore the respiratory system. In a person who is hyperventilating, what will happen to this person's pH?
Make sure you pause the thing. This is that video.
This person's pH should increase. The mechanism for this is that a person who is hyperventilating or breathing fast will breathe off more CO2, therefore decreasing the concentration of carbon dioxide in the blood, resulting in an increased pH. The kidney's role in acid-base balance is in regulating hydrogen ion excretion and reabsorbing bicarb. When the kidneys sense an increase in hydrogen ion concentrations, they will do two things. The kidneys will excrete hydrogen ion in the urine and reabsorb more bicarb from the filtrated plasma. Again, going back to the Henderson-Hasselbalch equation, as bicarb increases from kidney reabsorption, pH will increase. The opposite happens when the kidneys sense a decrease in hydrogen ion concentrations. In this situation, the kidneys will excrete less hydrogen ion and reabsorb less bicarb, all this leading to a lower pH. Okay, so example 2. Let's say a person has increasing amounts of hydrogen ion in their blood. What is the renal system's mechanism to decrease the amount of hydrogen ion? And what will happen to this person's pH? In a person with high levels of hydrogen ions in the blood, the renal system will excrete more hydrogen ions in the urine and reabsorb more bicarbonate from the renal filtrate. This will result in a decrease in the amount of hydrogen ion in the person's blood and an increase in the person's bicarbonate ion. resulting in an increase in pH.
So hopefully that helped clarify it a little bit for you. Like I was saying though, the kidneys, you can see why they would act a lot slower. It takes longer to filter things through the kidneys as opposed to just breathing faster or slower. But basically your buffer systems guard against these sudden shifts of acids or bases. They use a combination of methods, and the goal is just to keep you in that homeostasis, that 7.35 to 7.45 range. When you're talking about imbalances, there's 4 types of acid-base imbalances in the human body: respiratory alkalosis and respiratory acidosis. So looking at the lungs, you can either be basic, too acidic or too alkalotic, and then metabolic alkalosis and metabolic acidosis. When we're starting out looking at our patient, the go-to method of determining what type of imbalance your patient has is an ABG, an arterial blood gas. And what that is, it is a blood test that's drawn through the artery. It's usually done by a respiratory therapist in the acute care setting. You can have trained nurses or doctors. My recommendation is tell your patient it's going to hurt, otherwise you're going to get punched in the face. It is a very painful procedure.
Or understand.
Or yes. Also, make sure you hold pressure. You're poking an artery, so it tends to bleed.
Why is it painful?
Because you're poking an artery. And so you think about where they're going to draw from. Most respiratory therapists go for your radial artery. And you don't have a lot of fat there. You got tendons, nerves, and an artery. And they use a good 1.5 to 2 inch needle. And it's not 60 gauge. I believe it's a 20 gauge needle that they use. So it's a fairly significant size needle. And what the ABG does is it measures a couple things. It's going to tell you what the pH of the blood is. It's going to tell you what the partial pressure of oxygen is, your carbon dioxide, your bicarbonate, and your oxygen saturation. So, knowing what we know, we don't actually need to look at all these to determine if our patient is in respiratory or metabolic acidosis or alkalosis. We're only looking at 3 things. We're going to look at the pH, the CO2 or carbon dioxide, and the bicarb. So why would we look at the CO2? Does anybody know why? What is that going to tell us?
Because they're holding it in.
So is it going to tell us up there lung function, kidney function?
Lungs.
And bicarb, it's going to tell us our lungs or our kidneys.
Kidneys.
So since our lungs and our kidneys are our 2 buffer systems that we're looking at, that's why we only need to look at those 2 things, and the pH will tell us if they're acidotic or alkalotic. Pretty straightforward. So when you're looking at these, you need to know your normal ranges. We've already established that pH is 7.35 to 7.45. Normal range for CO2 is 36 to 44, on average 40. And bicarb is 22 to 26. This is a chart that I use. There's 100 different ways to memorize it, but when you're looking at your different imbalances, I just put this up here so we can take a glance at it, but we'll go back to it as soon as I go through all the imbalances. So, respiratory alkalosis. It's ineffective breathing. You're breathing too fast. Like we were saying, you're blowing off all this CO2. You're hyperventilating, you're blowing off all this CO2. Without looking, does anybody know why you would be hyperventilating? What are some causes?
Anxiety.
It's a big one. Anything else?
Head trauma that affects the respiratory.
That's a big one, head trauma. You think about, and even stroke patients, anything that's going to affect your brain and your neurological system. High altitude is also another one, and pregnancy, oddly enough, can make you hyperventilate. And they say it's because you don't have a whole lot of room going in there. You feel like you can't breathe, so you tend to breathe faster, so you tend to be more alkalotic than acidotic when you're pregnant. Patients that are in respiratory alkalosis will have a CO2 that is less than 40. So carbon dioxide's acidic. Our normal range is, does anybody remember what the normal range was?
36 to 44.
Yeah, so if you're blowing off all that carbon dioxide, you're going to want to be on the lower side. So when we look at respiratory alkalosis, we're looking at our patient. These kind of things, panic attacks, asthma, stroke, you can't treat the alkalosis, you have to treat the symptoms, the underlying cause. So if they're anxious, you got to calm them down. If they're having having a stroke, you need to, can't really reverse it, but treat the side effects, you know, increase, or decrease the intracranial pressure. Asthma, you have to treat the asthma. You have to get them to slow down, you have to get them to take slower, deeper breaths. On the flip side, acidosis. So if alkalosis is too fast, this is too slow. These are patients, like we talked about, the narcotic overdoses. You'll get this in cardiac arrest patients, because typically we get on scene, how long does it take to establish an airway and get good ventilations? If you don't have an airway, how frequently are you stopping to bag your patient or to do CPR? So these patients are going to be at an increased risk for acidosis. You also have to think about this with your paralyzed patients, your quadriplegics. Their diaphragm does work, but they tend to have lower respiratory rates. So, going back to your COPD, acute versus chronic acidosis. So, why did you ask about that? Well, what do you think a COPD patient, why would they be?
They can't breathe. They're not pushing out, they can't push out as much CO2.
So that air's getting trapped in their alveoli and
They're becoming, wait a minute, and I, their pH going up. No, going down, going down, going down.
CO2 is an acid or a base?
Acid. Base. I don't know. That's all I'm comfortable right
Do
now.
you need to phone a friend?
Yeah, I'm tapping Ashley. I'm tapping in Ashley.
Why are you
Oh, So what was the question again? I'm sorry.
COPDers. They
Okay.
hold in CO2, so it makes them
Ask about it.
Yes, CO2 is an acid, so they get air trapping. So they're not breathing off as much CO2, so yes. So when you're looking at an ABG for these patients, they're going to have CO2 levels that are going to be higher. Our normal range is 36 to 44. They're going to be in the 40s, the 50s, the 60s even. And so you have to take that into consideration when you're treating the imbalance. Their CO2 may be higher, but they may not have an acid-base imbalance because that's where they live. So you have to know what's normal. The really big thing is know what's normal for your patient. Our body has a way of keeping its own homeostasis, and for those, unfortunately, they live with higher CO2 levels. Now, that being said, if you see an 80, 90, or 100, that's not normal. You should probably treat that. But your respiratory acidosis patients are going to have CO2 levels that are greater than 40, typically, and a pH that is less than 7.35. So if we have the lung imbalances, we also have the kidney imbalances. Metabolic alkalosis is caused by GI or renal loss, so that will be any of your vomiting, your diarrhea. These are people that are on diuretics, and also people with Cushing's syndrome or excess steroid use. They're going to be, through all of this GI loss, they're losing bicarbonate, and so their bicarb levels will be greater than, I said that wrong, I apologize. They lose their acid, so the body tries to replace it, the kidneys work to replace it, and they actually have high bicarb levels, and they're going to be above 25. So if you're losing all this volume, the treatment is actually to replace it. So whether in the hospital or pre-hospital, you get a patient that's hypovolemic, what's your first on treatment? What kind of fluids? Do we always use LR?
No.
Water.
What do we usually use?
Normal saline.
Normal saline. So, does anybody actually know what the pH of normal saline is? Slightly acidic. Do you know what it is?
5.
No. Oh my gosh.
That was not, that was fine.
So I actually brought a bag of LR and normal saline. I just want you to take a look at its content. The third or fourth line will actually tell you what the pH is.
I'm sorry, what is LR? I missed
LR is a type of fluid. It's a lactated ringer. So you have normal saline, which they tell you is a lot like what you already have in your body, in your blood, but it's not actually accurate. LR is probably closer to what is normal for the human body. So when we talk about this, and what I'm showing you is we have a tendency when someone's hypovolemic to give a lot of normal saline. It brings up their blood pressure, it decreases their heart rate. But if you look at the content, the pH is 5. So if we think about this, you have a patient who's losing volume and becoming acidotic, and we're giving them a fluid that is already acidic. So we have to be careful when we're pushing these fluids because we can actually be making our patients worse instead of better.
Wait, so this is, if it's alkalotic.
Oh, sorry, we're on alcoholic. I
So
apologize.
this would be okay, right?
Yeah.
We're depleting the volume with an
Yeah.
acidic, but we're trying to get back to a neutral.
Yeah,
Okay.
sorry, I jumped ahead to the next slide. You're right. We're talking about alkalosis, but the point is, look at your fluid, know what you're giving. Even LR, they claim it's close to what the human body is, but it still has a pH of 6.5. So it's not much less acidic than normal saline is. But you were right. Normal saline would be good. No, you're very right. Normal saline is good for your metabolic alkalosis, but if you're in acidosis, which is the next slide, you might want to be careful about how much normal saline you give. And there are a ton of different fluids you can give, different concentrations. So, metabolic acidosis, the opposite, as she was saying. So, too many hydrogen ions. We have too many acids and we're losing too much of our bicarb. These are going to really, really big in your renal patients, your dialysis, your DKA patients. And oddly enough, in your alcoholic patients, you're losing so much through dehydration that makes them to be acidic as well. So their bicarb is going to be less than 25 and their pH. Which brings me back to this chart. This is just, like I said, the easy way to remember it. Just write down your 4 different imbalances. Your problem. I don't know, 30, 40. You know that it's No, we're just
hard
talking
to
about
memorize. That's fine.
If you're not a visual person, but you like your mnemonic devices, Rome is a good one. Respiratory opposite, metabolic equal. And what this means is, when if your pH goes up and your CO2 decreases, then your CO2 will decrease. And when your pH decreases, your CO2 will increase when it's respiratory. And for metabolic, I know I don't do well with the mnemonic, I have to draw it out, but for metabolic, they're both going to be the same. If your pH increases, then your bicarb is going to increase, and if your pH decreases, your bicarb is going to decrease. So, respiratory opposite, metabolic equal. Apparently I have another video to show you too.
So funny if something funny popped up.
YouTube's all about the ads these days too.
pH is an indicator of acidity. The body's blood pH is strictly regulated within a narrow range between 7.35 and 7.45. This is because even minor change in acidity may have devastating effects on protein stability and biochemical processes. Normal cellular metabolism constantly produces and excretes carbon dioxide into the blood. Carbon dioxide combines with water to make carbonic acid, which dissociates into hydrogen ions and bicarbonate. This is an equilibrium, meaning all of the components of the left and right sides coexist at all times, and the concentration of any component is determined by that of others at any given moment. The rule of thumb is an increase in concentration of any component on one side will shift the equation to the other side, leading to increased concentrations of all components on that side, and vice versa. This equilibrium is central to understand acid-base regulation. Continued carbon dioxide production by all cells of the body drives the equilibrium to the right to generate more hydrogen ions. Because pH is basically a function of hydrogen ion concentration, more hydrogen means higher acidity and lower pH. Normal metabolism therefore constantly makes the blood more acidic. The body must react to keep the blood pH within the normal limits. This is achieved by two mechanisms. Elimination of carbon dioxide through exhalation. The amount of carbon dioxide exhaled by the lungs is regulated in response to changes in acidity. A decrease in pH is sensed by central or arterial chemoreceptors and leads to deeper, faster breathing. More carbon dioxide is exhaled, less hydrogen is made, blood acidity decreases, and blood pH returns to normal. Pulmonary regulation is fast, usually effective within minutes to hours. Excretion of hydrogen ions and reabsorption of bicarbonate through the kidneys. The kidneys control blood pH by adjusting the amount of excreted acids and reabsorbed bicarbonate. Renal regulation is slower. It usually takes days to respond to pH disturbances. Although all of the plasma bicarbonate is filtered in the glomerulus during the first step of urine formation, virtually all of it is reabsorbed back into the blood. Most of this reabsorption happens in the proximal tubule. The amount of reabsorbed bicarbonate in the proximal tubule is regulated via a number of mechanisms in response to changes in blood pH. It increases during acid loads and decreases during alkali loads. While the proximal tubule basically returns filtered bicarbonate back to blood, the downstream collecting duct generates new bicarbonate by actively secreting acids. As protons are depleted from the distal tubular cells, the equation shifts to the right, producing more bicarbonate, which then exits into the blood. Hydrogen ions secreted into the lumen combine with urinary buffers, mainly filtered phosphate and ammonia, to be excreted in urine. The ammonia buffering system is particularly important because unlike phosphate, which is filtered in fixed amounts from the plasma and can be depleted during high acid loads, ammonia production is regulated in response to changes in acidity, and its concentration may increase several-fold when necessary. Blood pH is the main regulator of acid excretion, but potassium, chloride concentrations, and several hormones also play important roles. Pathologic changes may cause acid-base disturbances. Acid acidosis refers to a process that causes increased acidity, while alkalosis refers to one that causes increased alkalinity. It's not uncommon for a patient to have several processes going on at once, some of them in opposite directions. The resultant plasma pH may be normal, too acidic, called acidemia, or too basic, called alkalemia. Acidosis may result from inadequate function of the lungs, which causes arterial carbon dioxide to accumulate. This is respiratory acidosis. On the other hand, metabolic acidosis may result from excessive production of metabolic acids, ingestion of acids, decreased ability of the kidneys to excrete acids, or loss of alkali. Metabolic acidosis is characterized by primary decrease in plasma bicarbonate. Alkalosis can also be either respiratory or metabolic. Respiratory alkalosis is caused by increased ventilation, resulting in excessive exhalation of carbon dioxide. Metabolic alkalosis can result from excess loss of acids through the kidneys or gastrointestinal tract, bicarbonate retention, or ingestion of alkali. Metabolic alkalosis is characterized by primary increase in plasma bicarbonate.
So basically, she summed up everything I did in 5 minutes, but I hope that made it a little clearer. Are there any questions so far?
Is that why they give bicarb renal patient for the cardiac
And I'm just going to touch briefly on compensated versus uncompensated. It gets a little tricky, but this is a very basic lesson on acid-base balances. So basically, you have either your lungs or your kidneys are in balance, but when one is in balance, the other one will work to try to fix it. So if you're in respiratory acidosis, your kidneys will work to make it a normal pH again. And when you're looking at your ABGs with these patients, when they're uncompensated, your pH level will be off, and it'll tell you if you're acidotic or alkalotic, as well as your other numbers. But when you start to get compensated, while your bicarb or your carbon dioxide might be elevated or decreased, your pH will be normal. So if you're looking at your numbers and you're saying, the CO2 looks high for this patient, but the pH is normal, you may start to think, well, they're compensated and the kidneys are working to balance that out. This is all just kind of summarizing that. And the opposite is same for the kidneys. If the kidneys are acidotic or alkalotic, the lungs will work to try to balance that out as well. Okay, so practice ABG. If these are your values, you get your patient, these are the values that come up, you hand them, you're the doctor. Hand them these ABGs.
metabolic alkalosis.
You sure about that?
Myself, but
Be better as a group test unless you really just want to do it individually.
Group
test.
Group test, yes.
Wait a minute. It's pretty straightforward. So we've already established what is a normal pH range.
7.35 to 7.45.
That's right.
4, 5.
You can count.
All right. And on the back table.
Oh.
That back table?
No, this one right here. What are the two regulatory systems in the human body that help us maintain an acid-base balance.
Lungs and kidneys.
I knew you could. How do the lungs work to help regulate acid-base balance? And I'll give you the multiple choice.
Okay.
Increase or decrease respiratory rate to either hold on or exhale carbon dioxide. The lungs do not help regulate acid-base balance. Or the lungs expand to allow more oxygen to be stored into. Alright. True or false? The kidneys work faster than the lungs to correct acid-base imbalances in the body.
You say that again, I missed it.
True or false? The kidneys work faster than the lungs to correct acid-base imbalance. Very good. Alright. So you have a patient with a pH of 7.25, a CO2 of 39, and bicarb of 15. What acid-base imbalance would you expect him to have?
Can I give you my numbers again?
pH of 7.25, CO2 of 39, and bicarb of 15.
Metabolic acidosis.
I'm proud of you. Why?
One for the police.
Why?
Because it's in the acid range for your pH. It's under 7.35.
Mm-hmm.
Your CO2 is normal. I got this. Your CO2 is normal, and your bicarb is off.
It's off. Is it higher or low?
Give me the number
It's
again.
15.
Oh, it's low.
Nice.
I mean, I went to 4 years of nursing school and I didn't remember it that quickly.
Yes, that's part of the education, I'm just telling you.
Alright. A patient presents to the emergency department and metabolic alkalosis after several days of vomiting. What is your initial treatment for this patient? A patient presents to the emergency department and metabolic alkalosis after several days of vomiting. What is your initial treatment for this patient?
Stop the vomiting.
Zofran.
Maybe.
Alright, what is your initial treatment for this patient to treat the alkalosis?
Fluid. Normal saline.
LR.
Both are correct, yes.
All of the above.
Oh,
That's always
One
the
at
If
each arm.
saline's more acidic and they're
Yep.
alkalotic, I would go for the more acidic fluid.
One at each arm.
2 bags.
So that's that tone.
Plastic.
No, when mine starts in recess. When the bell rang and the credit started.
PS 41 or something. What's the class called?
Recess class or what was the school?
Their school was like PS 140 something.
I just remember the really
Alright,
tall.
guys, I only have 2 more questions for you. You're free to use more questions. It's a free class, it's an open class. Okay, so your patient has a pH of 7.5, a CO2 of 21, and a bicarb of 25.
So there's pH,
7.5.
respiratory,
They're having a serious conversation.
acidosis, alkalosis. That's what I meant. Okay, what I
You
meant.
sure?
Yes.
What is it?
Okay.
What'd you say?
Blood. Respiratory alkalosis.
So why?
Because they told me I was wrong.
Well, let's think about it. So we have a pH of 7.5. Is that
It's
acidotic?
high. Or it's
Alkalotic.
Alkalotic.
Alkalotic. Alright, they have a CO2 of 21. Is that high or low?
Low.
They have a bicarb of 25.
That's low too. That's what I'm saying, they're both low.
So
It's
It's normal. It's a trick question. It's respiratory. I'll say
It was
that.
fine. He was faking.
so that's normal?
Yeah, because what is normal bicarb?
26.
Alright,
Respiratory fluid.
last question.
Final Jeopardy, folks.
Final Jeopardy. So you have a pH of 7.5. I really like 7.5 apparently. A CO2 of 45 and a bicarb of 35. You care to share?
that's how I did it in nursing school.
Yeah.
So like my left hand was pH and my right hand was.
So you made your own choice. I like that.
But they They were both high.
They're all.
So
Everything's high.
Metabolic
It's all like
acidosis.
this.
Metabolic alkalosis, you sure?
I think so.
Go with it. Always go with the first response.
So your pH was 7.5, so that's alkalotic. Your CO2 is 45, is that normal?
Yes.
It's
It's on
not
the higher
technically
side.
normal, but it is on the higher side. So what is your body trying to do?
Compensate.
So you could say it's partially compensated, metabolic. Do you have any questions, concerns, or comments?
I do.
What's up?
So in the hospital settings, someone that is in DKA means, their blood sugar is really, really high. So the protocol is, besides the glucomanner, I don't know what you guys use, but, flush them out with fluids. So it's usually about 2 liters or more, depending on what their weight is. Insulin given in units, an insulin drip, and then bicarb. Explain the bicarb.
Let's talk about it together.
Okay.
So you've got.
Because I need to dummy it down so that way I know.
I think Deb might actually have a better answer for this one. But, so DKA, what is it?
So it's high blood sugar,
But what does DKA stand for?
diabetic ketoacidosis.
Acidosis. What is
So
bicarb?
high
Oh, it's a bad basic.
Yeah, so you have a patient,
count.
they come in DKA, they're severely dehydrated, so let me see if I can go back to that slide. So we were talking about renal patients and metabolic acidosis. You are. DKA is so complicated, you would.
I'm sorry,
So
I
much-
don't use bicarb to correct that.
Huh?
We don't push bicarb to correct DKA in ICU.
See, we do, so.
In the ER setting, we're talking about your DKA patients that come in like altered mental status, Kussmaul breathing, or just all patients?
Just any DKA, like if they meet a certain criteria in their blood sugar, we give them, it's part of their protocol. So.
I guess you can make an argument for both if you correct the underlying problem.
The
which
thing is,
DKA,
if you give them adequate insulin and you're gonna push all of your it goes to the cation and anion, you're gonna push all of your negative ions into the cell with that insulin, then a lot of times it will correct that acidity and therefore correct your bicarb without pushing bicarb. Because the body uses bicarb really rapidly.
Yeah.
When you push it in a code situation, it's
Right.
used up very quickly.
Right.
So a lot of times that's not what corrects it, but giving the actual insulin and moving your ions into the cell and correcting your anion gap will in turn correct your bicarb.
Well, I think that's why they give it initially in the ED, is that quick correction.
I was gonna say,
And
like,
like in a
that's
critical
pretty good.
situation,
Yeah.
if you're gonna be intubating them.
Managing.
But I mean, we don't, these patients are usually walkie-talkie, they're.
Really?
Yeah. I mean,
What do you mean?
That's not our protocol.
walkie-talkie, they're
But I think
having a
that's-
conversation with me, their
I
sugar's
think that's
just high.
a really good point as to not only ER versus ICU,
Yeah.
but facility to facility
Yeah.
too. You're gonna have different practices and,
They've probably been burned previously.
yeah,
back in
I was gonna say you
bicarb,
probably.
so now it's CYA. I mean, that's how a lot of protocols get established,
It is.
is because someone was burned because they didn't do something, and now it's just protocol and everybody's gonna do it.
Because you're not gonna hurt them by giving them the
No,
bicarb.
I'd be interested to see what the evidence base, what the literature says about giving bicarb for DKA patient,
Yeah.
because it's not part of the protocol I don't know what facility you work at. At CMC, it's not part of the protocol for DKA,
Yeah.
which is interesting, because we use other corrective methods that, usually within hours, you can see a drop in their, or an increase in their bicarb and a drop in their CO2.
You also have to look at your, not just DKA, but all your HH and case patients and stuff like that. So your DKA patients probably live in a little bit more acidic state. But if you have one who's new onset DKA, then you're gonna wanna correct it faster than slower because they don't live there normally.
Can you hurt somebody by giving them too much bicarb?
You can make them alkalotic.
You can just.
Yeah.
I mean,
You
you
can
can
acidotic
the other
state.
direction.
You just bounce it
Correcting
around.
one.
You can unbalance them, the opposite direction if you give too much, theoretically, but usually you're not pushing that much that you're gonna give them too much, if they're that acidic, right? You put a drip on them, you're not gonna make them
Yeah.
too
I mean,
alkalotic.
they're not gonna be
Is
on
this
a trip or
is this
anything.
common in children, or is it more of an adult
What?
kind of the balance being thrown off?
Well, it does, you look at your causes. If you have an incredibly anxious child who's going around hyperventilating, then you have a type 1 diabetic,
Asthmatic children.
asthmatic children.
don't
But,
see
and then you look
it.
at your old people, or your older folks, you get, dehydration, they don't intake as much, or they get in a nursing home and they get C. diff and they go to the bathroom quite a bit. So, it's really not one or the other. All right, thanks everybody. Really appreciate it. You guys are the best.